At Philips Foundation, we believe that technological innovation and collaboration can help solve some of the world's most profound challenges in providing access to healthcare. Today, nearly half of the world's population lacks access to essential health services. 100 million people fall into poverty each year due to unavoidable healthcare costs. By working together with non-governmental organizations, local entrepreneurs, governments, and healthcare providers, at Philips Foundation, we developed a deep understanding of local healthcare challenges. We are committed to improving access to healthcare by leveraging Philips' expertise and deploying technologically enabled solutions, empowering local health workers and strengthening community and primary care, and by fostering financially sustainable and scalable healthcare delivery models. We contribute to good health for all by addressing the rise of non-communicable diseases, such as cancer, cardiovascular, and respiratory diseases, improving mother and child care by making quality health care more accessible to mothers and children, and accelerating access to acute and emergency care through timely medical support in emergency situations. At Philips Foundation, we challenge the world around us to provide access to quality healthcare for 100 million people a year in underserved communities by 2030. By working with like-minded partners, we can promote health and well-being for all.
Good morning, good afternoon, hello everyone. We are super excited for you to join today's webinar. My name is Victor de Boer, Program Manager within the Philips Foundation, and I'm very pleased to welcome you to our 5th webinar of a series on strengthening access to quality healthcare for underserved communities. And before we jump in, let's maybe take a brief step back. Founded in 2014 on the belief that innovation and collaboration can help solve some of the world's toughest healthcare challenges, we, Philips Foundation, focuses on deploying technology that enables access to quality healthcare, strengthening community and primary healthcare, and building financially sustainable healthcare solutions. So today we will explore how social entrepreneurs and their disruptive models can offer ways to solve everyday healthcare challenges while complementing existing healthcare systems through their innovations and problem-solving approaches. And maybe if we go to the next slide, to further accelerate the development of potentially important opportunities for access to care, Philips Foundation has established a social impact investment vehicle back in 2021 that will support social enterprises through early stage and locally situation-specific investments and support. We hosted our very first investee roundtable conference last week, exciting week, where all entrepreneurs physically had a chance to meet each other, exchange ideas, thought-provoking ideas, and find synergies. It was really an exciting and energetic week, and on the back of that energy, we are very excited to now host this webinar specifically on the role of social entrepreneurship in the healthcare access to healthcare domain. So I will now hand over to my colleague Mahour, marketing leader for Philips Benelux, who will host today's webinar. So Mahour, take it away.
Beautiful. Thank you for the introduction, Victor. Super excited to be here today and to help moderate the discussion on innovative and disruptive healthcare. We're counting down. It's almost December 12th, and December 12th is the World Universal Health Coverage Day. Universal health coverage means that all people have access to the health services that they need when they need them without financial hardship. However, it is estimated that half of the world's population cannot access help that they need. And that means that about 100 million people per year are pushed into extreme poverty due to out-of-pocket expenses for health. Furthermore, the World Health Organization estimates an average of about 7 million deaths attributed to poor quality of care each year in low and middle income countries. This represents up to 15% of overall death in these countries. That's a huge, huge number. Now, social entrepreneurs in health offer something very special. They offer innovative and disruptive models to solve health access issues and to complement the existing health systems by deploying these innovative ways and enabling access to health services in underserved settings. In 2021, Philips Foundation established a social impact investment vehicle to support social enterprises through early stage and situation-specific investments and support to accelerate opportunities to improve access to care in underserved communities. In this webinar, we aim to explore the role of health social enterprises in improving access to quality healthcare in underserved communities. How we will do this today is through 3 panel discussions. We have 4 company representatives, Dr. Daphne from Access Afya, Dr. Robert of Panda Health, and Dr. Amr of Rology, together with Dr. Asher from Doctors. We will be having 3 panel discussions. In the first panel discussion, we will highlight innovative health service delivery models by working in underserved communities. Dr. Daphne and Dr. Robert will provide an overview of their social enterprises and talk about the innovative service delivery and business models that have enabled success and sustainability for the social enterprises. So starting with Access Afya, Access Afya's mission is to create sustainable healthcare models for the mass market. Access Afya has a standardized clinic in a box model that delivers chronic care, family planning, lab testing, child immunization and nutrition, pre- and postnatal care, general outpatient consultations, first aid, and much, much more. Dr. Daphne will share more about that later on. Then we're delighted to have Panda Health in his first discussion as well. The value proposition of Panda Health is designed to deliver an outstanding patient experience for mass market families in Nairobi, Kenya. It was founded in 2012, and Panda Health has always been committed to delivering excellent healthcare to Kenyan families. Panda has built a hub and spoke model with 19 medical centers in the Nairobi metropolitan area. It's a blended model for service delivery, combining remote and on-site care services. Now, in the second panel, we will have Dr. Emmer of Rology and Dr. Escher of Doctors. In this second panel, we will be addressing the health human resource shortage. To give you a little bit of an overview of Rology, Rology is an AI-assisted teleradiology platform that remotely and instantly matches highly qualified radiologists with cases from healthcare facilities based on the right subspecialization. Doctors is a novel healthcare marketplace that connects female doctors to millions of underserved patients in real time while leveraging online technology. In the third panel, we will have the opportunity to explore lessons learned from the experience of all 4 of these social entrepreneurs. So let's kick off with the first panel discussion. I will be introducing Dr. Daphne of Access Afya. Daphne, floor is yours.
Thank you, Mahour. Good morning, good evening from wherever you're joining. My name is Dr. Daphne from Access Afya. I'll start off telling you a little bit about the problem we're solving here at Access Afya out of Nairobi, Kenya. And we're solving a problem for the urban poor, peri-urban poor. And if you are the peri-urban or the urban poor in Kenya, then your healthcare is likely going to be unavailable, unaffordable, and of low quality. Standard global health private healthcare can cost up to 7 times the daily wage of low-income earners of an average of $3.5 a day. And where it is available and affordable, the quality is low and unreliable. 34% of private healthcare clinics in Nairobi alone are illegal and unlicensed. 48% of the time you're likely to get the commodities that you need, the drugs, the tests that you need in the public hospitals due to chronic underfunding. And Mahour has just told us 7 million people die due to preventable causes every year in low and middle income countries. And this is worsened by the fact that COVID has fractured health systems, but it's also an opportunity because now we can build back better primary health care. And so how are we doing this at Access Afia? Next slide, please. We are solving this problem through our Curafa franchise platform. This is a healthcare platform that enables local healthcare workers to be primary healthcare entrepreneurs. So we combine physical franchise clinics as our scalable delivery model and a virtual care platform that allows patients to be in touch with healthcare from anywhere they are. Physical clinics are located within 15 minutes travel time from the communities that they serve. Really driving that accessibility. We ensure affordability through an average $4 cost for a visit, covering consultation, medication, and diagnostic test, a one-stop shop right in your neighborhood. And we ensure quality through stock availability of medications, of diagnostic tests for 80% of an individual's healthcare needs that can be served through these primary healthcare clinics. Virtual care further increases access and enables individuals to be active participants in their healthcare. And this is accessible through multiple channels for any phone user, whether you're a basic phone user or a smartphone user, at affordable subscription rates of less than 6 cents a month. Next slide, please. And this is why we're really excited about this model. We currently have 13 primary healthcare clinics located in 4 counties in Kenya, and looking to grow this to over 100 in the next 5 years. We have engaged and built this model by engaging 100 plus healthcare workers who are focused on primary healthcare. These are nurses, clinical officers, and community health workers, expected to grow to over 1,000 in the next 5 years. And this model combines comprehensive online and offline care, offering at an ultra low cost of $4 a visit, and can serve up to 2 times the poverty line. 65% of the people we serve today earn an average of $2.5 a day. And, you know, one of the reasons that we just walked through when we were talking about the problem was that 7 million people are dying due to access to poor quality care. And so quality is a huge aspect of the model. This model, in its design, provides validated clinical quality that enables us to continuously improve towards the outcomes that we're looking to from a global health perspective. It leverages 450,000 patient-level data today, projected 2.5 million in the next 5 years. And this is a data-rich source to continue to provide the analytics for service and business improvements. And this is what constitutes the Curafa franchise platform. On a system level, this platform delivery model that is engaging thousands of healthcare workers, providing jobs, healthcare worker jobs for primary care, aggregating 25 plus data points from individual visits across the country today and across the continent in the next 5 years, provides a great source of longitudinal outcomes data that can further drive global health goals towards health financing and access to essential medications, assets, and continue to add value for not just the healthcare workers, but our end beneficiaries. Thank you.
Wonderful. Thank you so much for sharing, Daphne, and thank you so much for the work that you're doing. Moving forward, I would love to introduce you to Dr. Robert of Panda Health. All yours, Robert.
Hi, Mahour, and thanks so much for having me and having Penda to this webinar. You're going to hear a lot of similarities in the way that, I and Penda think about the problem, as you just heard from Dr. Daphne. And I think what I'll focus on is really viewing this problem through the lens of trust. So Penda's talked to thousands of patients over the 10 years that we've been in operation. And the one thing that we really consistently hear is the lack of trust in the healthcare system. So many people talk about negative experiences, and they say that they don't want to go back to the last place that they actually accessed healthcare. And trust is so hard to define, and it takes actually months and years to build up, and you can lose it in an instant. But there's two pieces that I want to focus on in particular from a problem standpoint. One is around clinical guideline adherence. That's a global problem. Everyone kind of in health systems all around the world is trying to figure out how we increase adherence to clinical practice guidelines. But in Kenya, only about 40% of care that's delivered is in accordance with national guidelines. And in a country where the average person spends about $50 per year on healthcare, to me, it's just such a tragedy to have more than half of that go to waste or to go to non-evidence-based treatments or diagnostics. So that's definitely part of the problem that Penda needs to address. The other part is the patient experience side. Long wait times, Dr. Daphne alluded to stockouts, which are a big problem and definitely lead to a loss of trust. And so really kind of focusing on the overall patient experience is a key part of the problem we need to solve. So when coming now to our solution, and I think you can go to the next slide, we basically focus on providing patient-centered, tech-enabled care. We have a network of 19 brick and mortar medical centers all over Nairobi. We're in 3 counties within Kenya. And then we also have a nationwide telemedicine service that is actually reaching thousands of people, even outside of Nairobi. And so every day we're actually providing care to more than 1,000 unique patients. We have a very highly tech-enabled, completely paperless workflow. And one of our key innovations is this clinical decision support. So that's basically guidance for our clinicians on more than 90% of clinical encounters at Penda. So over 300 different conditions that we commonly see in primary care have suggestions for the providers, because primary care is broad and we need help. We need to help our healthcare workers know what are the evidence-based treatments for the huge variety of things that they're seeing. The other part of our solution is to really always focus on that patient experience. And, again, Dr. Daphne alluded to the very low net promoter score in the healthcare industry in Kenya. And we've also really focused on that. We've achieved greater than 70%. And that's been really consistent for us. And it's not easy to do. It's through a combination of working on wait times and customer service and price transparency. All of those things are super important to us. So now going to the next slide, Mahour, the key disruption that I think people should take away is our special sauce is the ability to provide that really high level of care. And what I mean by that is the way health systems measure quality of care, but also the way patients view quality of care. We've figured out how to do that at a very low cost. And that fundamental disruption unlocks so many other things. It allows us to provide care in very low-income communities around Nairobi to the uninsured, which are the bulk of the patients in Kenya. It allows us to work with the National Hospital Insurance Fund, NHIF, and be a major provider for the government payer. And one of the things I'm particularly excited about is, even as little as 2 years ago, only less than 1% of patients paid by a subscription model. Everyone was paying fee for service in a very transactional way. In the last 2 years, now more than 10% of patients at Penda are actually paying using a subscription model, which means that they don't need to reach into their pockets every time they're coming into Penda. And that sets up a much more kind of longitudinal patient care relationship. So all of that is fundamentally disrupted by this very low cost of care, which is scalable.
Phenomenal, Dr. Robert. Thank you so much for sharing, and what a great job Penda Health is doing. It was really great, Dr. Daphne and Dr. Robert, to hear you talk about health service delivery models and how that can contribute to access to care. Now, we would love to address the next topic. And in the next topic, our second panel discussion will be around addressing the health workforce shortage. So the human capital that we're lacking, and how technology and innovation can help out there. So we would love to start with Dr. Amr of Urology. Amr, could you share how urology has been addressing it and what the main problems are?
Thank you, Maru, and thank you for Philips Foundation to have actually to arrange all of this panel and to have me in this panel. It's really my pleasure. So we are in urology. We solved the problem of the severe shortage and the misutilization of radiologists, and this is a really global problem. It's literally facing almost all over the globe. But when we look about Africa and Middle East, we can see that the problems take a new way of regarding the numbers overall. You can see some countries, they have only one radiologist for more than 800,000 citizens, have 1 million citizens, and some other countries which have one radiologist for every 1 million citizens. And this lack of radiologists lead to high latency in reporting time, and we know that diagnostic medicine right now is the main starting point for all the patient journey. So once you have this high latency in the reporting time, and some other times you actually don't have the accessibility overall for the such reporting and such diagnostic reports overall, which will stop all the patient journey and all the treatment journey for the patient. So from this problem, urology trying to solve this problem through an AI-assisted, next slide please, an AI-assisted teleradiology platform that help hospitals and radiology centers to solve the problem with a zero setup cost. So how we can match the cases from hospitals and radiology centers and the polyclinics with the optimum radiologist based on availability and subspecialty. So by the end of the day, we promise our hospitals and our polyclinics to have a fast and accurate and valuable final diagnostic report, and we have a very competitive turnaround time. And thank you for the technology overall, which has empowered us to do this. And one of the very important unique points, which is the cornerstone of our disruption model, which is it's a zero setup cost. So we don't require any kind of infrastructure because we know exactly how our infrastructure in our hospital looks like, and how much it's difficult to build the infrastructure overall. So from day one, we build our solution to be a zero setup cost, to empower every hospital, whatever the size of this hospital is, can work through our solution. So when we think about such kind of solutions, we think about how we can disrupt the teleradiology industry. And we have our model about which is we call the DBD for the disruption. So, and I think it's something. It's not. It cannot be implemented only about urology, but it can be implemented over in any industry actually. So if you want to disrupt an industry, you need to democratize this industry and also platformalization for this industry, and then it will be decentralized automatically. So we decentralize the teleradiology solution through our system because we reallocate the power. So we can connect to the radiologist, whoever he is, with the hospitals, which is already also whoever it is. So it's reallocate the resources for the fair distribution. Also, we do the decentralization through empower the hospitals to utilize their machines and also utilize the radiology devices overall. So they can work through urology 24/7 and covering all subspecialties and all of this stuff. So when we empower the hospitals to do this, they can build the capacity. And when you can build the capacity in every single facility, in every single healthcare provider, it will lead to decentralization automatically. So once we do this, it leads to the platformalization. So platformalization is when Volushi gives the access for every single healthcare provider, every single facility, hospital, whatever, whoever the location is, if it's in a rural area or metropolitan area or something like this. And also because we are a zero setup cost, so we don't require any kind of infrastructure from the hospitals to start to have all of to have all the diagnostic reports and so on. So this is empower the hospitals to be scalable as much as they can. By the end, our solution is democratize the teleradiology overall and the radiology in general, because you give the hospital right to choose. We are an on-demand, so they have the right to choose which kind of scan they wanted to do. They wanted to outsource and all of this stuff. And by the end of the day, you provide a high standard diagnostic report with in a very fast way and without any extra cost. And this kind of DBD solution overall, which is where we guarantee how we can disrupt and increase the accessibility for diagnostic reports for all of the rural areas, small hospitals, and also big hospitals. Thank you, Mahour.
Thank you so much, It's phenomenal to see what Radiology does, and your passion really does come across. So we will be moving to doctors now. We will have Dr. Asher, who will share a little bit about how they, within doctors, are addressing health human shortages using technology and innovation. Dr. Asher, welcome. Thank you for joining us today.
Thanks very much, Mahour. Can you hear me now?
Absolutely. Thank you. All the way from, you are in Nairobi now or the US?
Today I'm in Karachi, Pakistan.
Ah, there we go. Beautiful. Thank you for joining us, Dr. Asher. Could you share with us how doctors is managing human shortages through technology and innovation?
Sure, be my pleasure. So just to kind of frame the problem or the issue that we are tackling, it's estimated that there are about 300,000 female healthcare providers, and these healthcare providers include doctors, therapists, pharmacists, dentists, nurses, primary healthcare workers, midwives, etc. So a very broad range of healthcare providers who at any given time are excluded from the global workforce. There are usually 4 reasons for their exclusion. The first is hostile or toxic work environments, which discourage women from working in the public sphere. The second, rigid health systems that have not adapted to the workforce needs of contemporary women. The third is childcare or senior care responsibilities, which often impede or impinge, and again are not able to, because of the rigidity of the health systems, especially women are not able to juggle that, and oftentimes will have to make a Hobson's choice, which is always generally in preference of their families, and so they end up sacrificing their careers. And this is a choice which we should be able to provide them with a better choice. And that choice is to use technology to reintegrate them into the workforce. And that's basically fundamentally what we do at Doctors. If we could have the next slide. So at Doctors, what we do is we use digital technology to match the underutilized capacity of female healthcare providers, such as Zara, Aisha, Noor, and Rabia, to the unmet needs of healthcare health seekers, such as Shahnaz, who's a low-income patient in a rural village in rural Punjab, in Pakistan. And perhaps what's more important than just linking the patient to healthcare providers the right technology is the fact that these 4 care providers form part of what's called a patient care coordination team, so that the patient user experience or the user journey is really streamlined and harmonized. And it gives the end user, the patient, the confidence and that, they actually have access, real-time 24/7 access to a team which is available to them to address any issues that they might have. Now, typically the access is either provided through WhatsApp or a mobile app, or sometimes through audio where patients don't have access to smartphones. So what we have found, of course, is that having a human intermediary, somebody at the front lines who is able to physically interact with the patients, is absolutely essential. And so while the technology is a great democratizer of healthcare, it is not sufficient. It does require, especially in healthcare, we do require that empathetic touch, that healing power of the human intervention. Next slide. So from our perspective, the disruption that we're bringing is that we're not just reintegrating women into the workforce, we're actually also enabling them to provide or be resources for their communities, especially in the context of peri-urban or rural Pakistan, which represents basically 80% of the population. So if you look at Pakistan as a country, there are approximately 225 million people in the country and growing. I would say close to 200 million of those people live in urban slums or in very similar to the ones in Nairobi, for example, Kibera. For those who are from Kenya will recognize this. There are slums like that in, for example, Orangi, which is a slum in Karachi where 2 million low-income people reside. And of course, the rural areas where there is a mismatch between the availability of doctors or healthcare providers and the needs of these patients. So what we have done is that we train, equip, and deploy frontline health workers who we call Goody Bajis. Goody Baji just simply means good elder sister. And these Goody Bajis basically have tablets. They live in villages. They have 4G connectivity. They go door to door. They're able to do home health visits. They're able to do town halls in which they provide women with, or all comers actually, with access to a variety of different services and benefits. For example, they teach women self-defense. We have a mixed martial artist, an MMA trainer who has done master training of these Goody Bajis. And so it gives women in these communities the confidence to be able to defend themselves in any kind of security or precarious situation where the security is compromised. In addition, these women serve as pharmacy access points. So we have a telepharmacy model in which pharmacists remotely monitor and dispense drugs, and those drugs are actually available but at the Goody Baji point of access. So she is very much a courier and is able to provide a patient. So imagine a patient in a rural setting who basically has a teleconsultation with a doctor. The doctor prescribes, the prescription is digital, it's monitored in real time by a pharmacist in real time who's part of the same coordination team. And that pharmacist authorizes the Goody Baji to provide the medication to the patient at point of service. So that type of model is really powerful because it enables what's called continuity of care. The entire customer journey can be provided in a single episode. And in terms of where we're headed next, we're looking towards leveraging the, technology, especially on the diagnostic side. So for example, with Philips, we've been looking at the use of point of care ultrasound in the context of emergency antenatal care. So these Goody Bajis are also trained in acute cardiac life support and basic life support, or will be in many cases. We're still going through that process. And the idea there is that in real time, they can actually do life-saving interventions guided by remotely located radiologists or remotely located OBGYNs. So once you have that type of capability, it really opens the door to global integration of human health resources using telemedicine. Finally, I want to say that when you have these frontline community workers, it also enables what's called collaboration. And so in our case, we have collaborated with Unilever, with Philips, with Reckitt, with GSK, with a large number of multinational companies which are all interested in rural market access. Of course, many of these markets are growing furiously. They are the emerging markets of the future. And a lot of these large multinationals really want to be able to serve these communities while retaining quality and enabling affordability. I think if my time's not up, I'm happy to answer questions now or later.
We will thank you for your presentation, first of all. That is so impressive, and just phenomenal to hear the inclusiveness. So thank you for that, Dr. Escher. We've touched now upon the topics of health service delivery. In the last panel, we spoke about human shortages and how we address those using technology and innovation. So we're going in towards our last panel. In this panel, we really want to talk about the learnings that we have, how to enable sustainability, and share some of the experiences that we have among our speakers today. Should you have any questions, feel free to put them out in the chat as well. First of all, I see a couple of things coming in. First one is addressed for Dr. Daphne. Dr. Daphne, Access Afya aims to deliver quality healthcare in very underserved populations in Kenya. In these communities, there's a low insurance coverage. Most payments are out of pocket, and there's also low purchase power. What are some challenges that you have experienced in getting a balance between making care affordable and running a sustainable enterprise?
Thank you, Mahour. I'll start by just making a general kind of statement on context. So 80% of Kenyans have no insurance coverage. Just to give you an idea of what the insurance penetration is like in Kenya, because we have a population of 52 million people. And two is that a lot of it's an estimated 4 billion spent on primary healthcare from out-of-pocket payments in Kenya as well. Again, just to give you the kind of big picture of what that looks like. And so 50% or almost 50% of healthcare delivery today in Kenya is delivered by the private sector alongside the public sector. That just shows you the gap that there is to fill for this kind of gold standard that is applied of public-driven healthcare systems for social good. You know, I mentioned chronic underfunding as one of the major challenges that governments, not just in Kenya and Africa and low and middle income countries, will continue to face for the foreseeable future. And so there's a huge role, obviously, for social enterprise. And so some of the kind of key things I think that we have had to tackle in building this solution, I'll just focus on kind of three main things. One is infrastructure costs. While typically, you know, solutions aim to replicate setups that work in other settings where affordability is not an issue, if you're thinking about solving that problem in low income, you have to rethink, and that's what we had to do. We had to redesign from the ground up. So thinking about your clinic location, it's a 500 use of space, 500 square foot space, workflow redesign, cross-training of the team so that they're able to do more with less, and then tech to be able to, utilization of technology to be able to still support a global standard of care. So that's one thing in terms of how we address the infrastructure costs and got that down to an ultra low clinic setup cost of $15,000 for a brownfield location, you know, if we fitted that out in a building, and $30,000 if we're fitting that out, including the structure where there is no building. And then the second kind of area that I think is a major challenge to creating affordability is the high cost of equipment and technology. So high capex and opex, and Amr has you know, clearly illustrated with their solution how this lower cost asset sharing, teleradiology, point-of-care ultrasound can help drive down cost and increase access to care and improving the affordability. We've been able to provide ultrasounds at an ultra low cost for pregnant women at an ultra low cost of $6. This is through the application of these digital health technologies like ours that are coming to the market, and then our deployment of this as part of our platform and comprehensive solution. I'll stop there. And there's several other kind of key areas, but in the interest of time, I'll stick to those two.
Perfect. Thank you so much, Dr. Daphne. Then I have the next question coming in for Dr. Robert. Dr. Robert, Penda Health has been able to expand to 21 clinics delivering high-quality healthcare in underserved communities. What are some lessons that you can share on what has enabled growth despite the challenges of running a social enterprise?
Yeah, it's a great question. And I think a lot of people almost view it as, ooh, like you're trying to serve low-income communities. It must be hard to scale. It must be hard to build a profitable business model. And of course, there's aspects that are challenging, but for me, it's the most exciting, and it's the most exciting place to be building. And it's where we have kind of really the most growth potential. That market, at least in Kenya and most of East Africa, is much, much bigger than the top 5% market, which is currently served by incumbents. And I'll just give you two examples of why this is exciting. So one is that in healthcare, volume equals quality. The more you do something, the more you sort of get into those entrenched pathways of how we take care of people according to standard operating procedures, the better quality of care there is. And that's been proven in surgical settings and outpatient settings, et cetera. So at Penda, we vaccinate between 3,000 and 5,000 babies a month. We get really good at it. Deviations from that process become very obviously apparent. And so if you're only building for sort of the top 2, 3, 5%, it's much harder to get the power of volumes, what the power of volumes can bring for your quality processes. The second aspect is from a product perspective, and I'll give the example of our telemedicine service. Some of the sort of high-end incumbents in our market are trying to get into telemedicine. But I think because volumes are few and it's a new service, it's hard to really sort of staff and build that appropriately. Meanwhile, for Penda, we have 500 WhatsApp conversations per day with our patients. We're doing dozens of paid telemedicine consults every day. And in the room, actually just behind me, we've invested in a team of clinicians and receptionists who are 24/7 there, ready to take calls and things like that. And those are things that if you're not building for the mass market, you can't invest in those kinds of really exciting things that drive both the business side and the quality side.
Beautiful, beautiful. Dr. Amer, I see a question coming for Rology. Rology has successfully been able to raise funding to scale the enterprise. Many social entrepreneurs, however, face challenges accessing funding to scale. What are some lessons that you can share with us?
Yeah, thank you, Mahour, for the question overall. I think I have a very special opinion, personal opinion in this, because overall, I'm not a big believer in which is called social entrepreneurship or social entrepreneur or something like this. Entrepreneur by DNA, it should to be entrepreneurship by DNA should to be seeking for profit, seeking for sustainability, and sustainability coming from profit overall. So how we can do an impact? It's not about building a social entity or something like that, but at some, of course, this is something can be needed in different sectors overall. But in healthcare, we need to build an healthcare organization which is seeking for profit and all of this stuff, and we need to build the innovation in our DNA to make a good unit economics and the good margins and all of this stuff, with keeping the cost for the cost for our patients, our healthcare providers, affordable overall. So starting from this, you can build your growth and build your scalability overall to be able for fundraising and to be able to raise funds in a good way overall and so on. So the secret sauce, if we can say, about fundraising is you have if you have a good unit economic and if you have a real value proposition, it will be I can say it will be easy to fundraise overall. And to comment about this question, by the end of the day, if we did a lot of fundraising but we didn't provide what we promised for our clients, it's not a success overall. So the main success for any entity should be if this entity can deliver what this entity promised the client, the patient, and or not. So we acknowledge. We not celebrate the fundraising overall, but we celebrate that we help more than 500,000 patients to be diagnosed in an accurate way and in a very fast way as well. So once you will have this mentality, this mindset, actually it will unlock a lot of other other fundraising.
So it all starts with passion again, huh? Beautiful.
Yes, of course.
Thank you so much. I see a lot of questions coming in. Let's focus one on Dr. Escher. Dr. Escher, I see a question coming here for doctors. Doctors has leveraged technology to run a successful enterprise, improving access to health services in underserved communities. From your experience, what lessons can you share on how social entrepreneurs can leverage technology to create impact and reduce health inequalities?
Excellent question. So Mero, I think what's really important is for technology. Technology, as I said earlier, is a great democratizer, but it must be user-centered or patient-centered. And so as an example, telemedicine is a relatively nascent industry or nascent, the use of telemedicine is fairly new. And in many countries, especially in emerging markets or developing countries like Kenya and Pakistan, etc., the use of telemedicine is still very embryonic, I would say. What that means is, so ideally, the tools which are most commonly used should be integrated into these models. And so Robert mentioned this, that they get a lot of calls through WhatsApp or a lot of interactions done by WhatsApp. The same is true for us. So rather than trying to replace technology that's already being used, one should leverage off of existing tools and integrate those tools into platforms that have, electronic medical records or other types of capabilities. And so in our case, we are integrating WhatsApp with our digital health platform because our primary communication with our customers or our patients occurs through WhatsApp. And so behavioral change takes time. And I would say that it's much better and much easier to use tools which patients are already used to using, and to do so in a way which is obviously compliant with regulation, regulatory, etc., but which can be seamlessly integrated into the type of diagnostics and other types of technologies that we want to offer to our patients.
Thank you, Dr. Escher. So we have one question coming in. It is actually addressed to everyone. To what extent do you think existing tools, like in Europe and in the US, are suitable for use in the settings that you are working in? Are completely new tools needed, or is it possible to adopt existing tools in a different context? Let me go ahead and ask Daphne. Dr. Daphne, can you maybe share your view?
Thanks, Maru, and that's a great question. I do believe that there is no need to reinvent the wheel, right? I think if we're building correctly, we're building to be able to customize and localize solutions to be adaptable to the communities that they serve. And so, of course, while there are externalities, I think there are a majority of digital diagnostic devices, platforms as well, that can be adopted to kind of use cases here. We have a combination of custom and off-the-shelf technology. So we've built the technology to complement our Curafa franchise platform, to complement what was not feasible in from the existing sources that we had. So, for example, we utilize off-the-shelf inventory management systems and electronic medical record system, but in the design of our patient management kind of platform, or even for our digital kind of health devices, we built those and in-house and customized them to our specific use cases. So, for example, because of digital literacy, we want to, and smartphone access. And while you might have, good penetration of smartphone access in Kenya, primarily maybe focus on WhatsApp and Facebook, and not for kind of the range of the full applications that, a different group of people are using them for. And so you still need to kind of design the solution in a way that a basic phone user who has these barriers of digital or cultural even kind of circumstances where maybe there's one phone in the household and it's the husband who has that phone. And so you have to kind of tweak the solution to the context. But in short, I think there is room, and I think it's obviously more efficient to be able to adopt, kind of what works and then redesign and use in a way that is applicable for the local context. And then beyond that, there's a lot of fragmentation in healthcare, at least here in Kenya, is the collaboration between, all the different kind of solutions that they are here. Social enterprises or entrepreneurs don't need to kind of build, each kind of build a separate kind of solution that have kind of minor, variations, but is there, kind of partnership through collaboration to be able to create value, and really focusing on your areas of specialization, to be able to maintain costs. And obviously the end goal is, can you deliver an affordable service at a cost that is sustainable and be able to grow it? So I would just add that the importance of this kind of collaboration.
Beautiful. And it was also very insightful to learn, for example, that tools like WhatsApp or mobile phones are used, simple technology for US, Europe are used in a different way to really evolve and disrupt the way that we do healthcare, specifically in this industry. I think that was an example actually that Dr. Robert mentioned about the use of WhatsApp in the clinics. Dr. Robert, do you maybe have some more examples of how technology is a driver for your clinics with Penda?
Yeah, I've gotten a lot of questions in the chat and over time about how technology is really used to improve quality at Penda. And sometimes the best example is actually a mistake. So I'll tell you about an error that we did and how that kind of led to an improvement in our quality. So for our clinical decision support, which is this really key tool, it serves up basically recommendations for our clinicians. And so, and we have a clinical team that reviews guidelines and puts those suggestions into our system. So we actually mistakenly entered for a diagnosis of bacterial conjunctivitis, an infection in the white part of the eye. We had entered in an eardrop formulation of antibiotics instead of the eye drop formulation. And so that started appearing as a suggestion for our clinicians. And it took about 1 week before a patient safety report was raised by our frontline staff saying, hey, do you know that this is like the wrong formulation of this treatment you're recommending? And we were like, oh my gosh. And we, went into the system to find out what was going on. We corrected the error, but when we looked at our back end, which tells us what percentage of the time our guideline recommendations actually accepted, and across Penda, it's about 85%. For that suggestion, it was 3%. which meant in the 1 week that that mistake was live, it had only been accepted 1 out of 30 times that the suggestion had been served up. And so I think that's a really key part of this whole thing, is it's not just that front-end technology of here's the suggestion. It's actually an operating system within our branch network where there's conversations between our providers talking about where are we missing on guideline adherence and how do we actually improve the clinical guidelines that are served up in our system.
Such a great example. We have time for, I think, one more question. Dr. Escher, do you think that your business models or the social enterprises in general would be suitable in other, maybe less developed or less emerging markets in Africa and the Middle East? And what are some preconditions for your companies to enter a different market or country? And then let's see if we can get the mic working. Beautiful. Thank you.
Sure. So there are, as I mentioned earlier, there are 300,000 female healthcare providers licensed who are out of the workforce. About 50,000 of them are in Latin America, Africa, 25,000 in the Middle East, North Africa, 125,000 in Asia, 50,000 in Europe, 50,000 in North America, just to give you some stats. Now, imagine if those 300,000 women were universally licensed to be able to deliver services anywhere in the world. A lot of women in our country are actually dual licensed. They take United States medical licensing exams, also known as USMLEs. And so that might be a platform that can be used universally to say, okay, if you're actually, if you pass this exam, then you're licensed to practice telemedicine anywhere in the globe. And that will really unleash incredible human potential. And so I would urge Philips to advocate for a universal medical license.
Beautiful. Thank you. Thank you for sharing that. There are still questions coming in through the chat, and there will be a full report out of the questions as well. On the flip side, I also want to mention that the websites of these 4 companies, you can find them on our Philips Foundation website as well. So there's absolutely the possibility to reach out as well for more information. And if you would want to have more time, I would love to thank all the speakers that we had today. It was incredible to learn from you, and so much respect for what you do and how you are disrupting healthcare and enabling that there is access to care. Very excited for the 12th of December. Thank you for the highlight. Now, we will be having one more of these webinars in February, which will be focused on mother and child care. So stay tuned for that. The recordings of this Philips Foundation webinar will be shared with all the participants. So thank you for joining and straightening the access to quality of healthcare webinar. Appreciate everyone joining from the globe, and mostly the presenters, of course, today, but also all the Philips Foundation people on the background that have been silently working outside of the spotlight. So huge thank you to the Philips Foundation team as well. Have a wonderful rest of your day. Thank you, everyone.
At Philips Foundation, we challenge the world around us to provide access to quality healthcare for 100 million people a year in underserved communities by 2030. By working together with non-governmental organizations, local entrepreneurs, governments, and healthcare providers, we can promote health and well-being for all.